When we brought Oliver to hospital, and in that journey throughout that last year of his life, so it wasn't just the last hospital, I truly believed that the medics, clinicians, nurses, doctors knew everything there was to know about a diagnosis of autism and a learning disability. I thought they knew more than me, and they looked us squarely in the eye and told us, we will tell you when you need to be worried. And what your listeners might know is that Oliver's brain, as a result of that drug that was given, it swelled so much it was bulging out the base of his skull. We're almost embarrassed to ask those questions. If we constantly go around blaming, pointing fingers, we want to bring about real change. And to bring about real change, we must work together collaboratively.
Paula, thank you so much for joining me on Believing People.
You are more than welcome.
It's lovely. It's lovely to have you here. A lot of things I want to cover today, because obviously such a tragic but interesting story that does need to be told. Oliver's story shows what can happen when lived experience from the person themselves and from their family is dismissed or overridden by professional assumptions. In drug and alcohol services, people are often doubted, judged, or written off very quickly. Why is believing people so fundamental to safety and dignity in treatment and addiction treatment?
I think it starts with bias. It starts with misunderstanding. It's about lack of education. It's about not always listening. And it's about not always accepting anybody that's different to ourselves. There's also a fear. So for me, it always comes back to education and knowledge. It's never acceptable, is it really? No. Especially in drug and alcohol abuse, when people need help and support most.
Can you tell me a little bit more about why it comes back to fear?
Well, I think people are always scared of what they don't know. It's the unknown, isn't it? And people don't always want to face challenges that they don't understand or feel unable to support. I think it's fear of the unknown and fear of unpredictability.
Absolutely.
And not many professionals want to put their hand up and say, I don't know.
Yes. That's interesting, because I guess looking back, how much of what happened do you think what was about lack of knowledge, and how much of it was about power? I think what I mean by that is I've naturally visited GPs myself. I work with doctors. I often found there's this, I call it the God complex. Do you know, when you challenge the doctor, it's almost like they don't like to be wrong. And sometimes I almost get the impression that when they also know they're wrong, they don't want to admit it because they're the professional. They're the ones with that extensive amount of knowledge and experience. How much of it was about lack of knowledge and how much of it was about power?
There was an awful lot of that actually in Oliver's case, and exactly why Oliver's death has become so high profile. Throughout Oliver's story, his voice and our voices were not heard. We were not listened to, and they were not seen as important. Red flags when Oliver was in crisis, as in after he'd been intubated. We, as Oliver's parents who knew him best, we could see things were going drastically wrong. We could see his life was in crisis. And when I say that, obviously he's intubated, and we could see he's looking very different. And we highlighted this to the doctors over and over. We kept saying things are going very wrong with Oliver. We're really worried. And they looked us squarely in the eye and told us, we will tell you when you need to be worried. His temperature was at 42 degrees and rising. And again, when I look back, I was running around with paper towels trying to bring that temperature down. He wasn't given any medication to control that temperature. But the doctors knew better. When we brought Oliver to hospital, and in that journey throughout that last year of his life, so it wasn't just the last hospital, it was the children's hospital before that. When he was in hospital, I truly believed that the medics, clinicians, nurses, doctors knew everything there was to know about a diagnosis of autism and a learning disability. I thought they knew more than me. In actual fact, that's my profession. I work with children with additional needs, focusing on autism. And obviously I'd lived with Oliver my whole life. And I honestly believed that they knew more. And not once did anybody put their hand up and say, I don't know. How can we help Oliver best? Not one person stopped to ask Oliver himself, who was very able, to say, Oliver, how can we help you? Nobody was brave enough to say, and I will use that word, brave. Nobody was brave enough to say, I don't know. And that's wrong. First of all, it's wrong. It was wrong for patient safety. It was wrong for Oliver because it cost him his life. But it also for our medics, it's wrong for them. You know, we wouldn't ask anybody to go and repair a car or an engine if they've not had this, they haven't got the skills or they haven't had the training to do so. Why do we ask our medics, our clinicians, our health and social care practitioners to go out and support individuals if they've not had adequate training to do so? And I just felt that was so wrong and it needs to be addressed.
I've got a lot of admiration for you. When I did Oliver's training, the thing that really struck me was right at the beginning. One of the first things you said, that this isn't about blame. It's not about pointing fingers. As a parent myself, and funny enough, I just had this conversation with your husband in the reception area. I think I'd find it really hard not to want to point blame and not, really want to, I guess, feel. I'm not saying you wasn't angry, but I just think it's really admirable that you're in this place where in this training you do say it isn't about pointing fingers or blaming professionals. Can you talk to me a little bit more about that?
I think generally that is the case. You mentioned about practitioners, so some doctors being godlike, and that was the case with Oliver. And Oliver's training is absolutely not about blame. The individuals that were instrumental in Oliver's death, I compartmentalise.
Yeah,
I don't think about those practitioners because that's not going to help anybody. However, 99.9% of practitioners want to do the right thing. They go into that profession, well, I'd actually say 100% generally, go into that profession to do the right thing. So we are not going to get anywhere if we constantly go around blaming, pointing fingers. We want to bring about real change. And to bring about real change, we must work together collaboratively as a team. And we must keep, in this instance, obviously Oliver's training is about autistic people with a learning disability, neurodivergent people. They must be at the very heart of everything. And we must learn directly from them. That is essential.
Oliver's autistic behaviours were repeatedly misunderstood, even when clearly documented. In drug and alcohol services, many people are autistic or have a learning disability without a diagnosis and often have long histories of trauma and exclusion. What risks does that create in services that are built around appointments, verbal communications, and this general expectation of compliance?
Huge risks, isn't it, really? Because obviously, again, it comes down to that ignorance from professionals, the stigma from our neurodivergent individuals. They are in crisis, as you just said, addiction. They're seeking support and help. And the help just isn't there, is it? So a huge risk to our communities that are desperately in need of support. And it just isn't there because, of course, traditionally, from my understanding, supporting people with addictions is usually talk and therapies. We're all familiar with Alcoholics Anonymous.
Yeah.
That is awful generally for a neurodivergent person. That is a therapy that is never going to work and actually would cause far more anxiety. And the impact of that on a neurodivergent person is that they will, if they're addicted already, they're going to seek further addiction. So the risk of, would we call them clinicians or therapists?
Clinicians, therapists, yeah.
Not understanding neurodivergent people, whether they're diagnosed or not, is very, very high. And this is exactly why we've always said every person, health and social care, working with the public, must all receive Oliver's training. And I've had, particularly from social care, practitioners coming forward and saying, well, we only have old people in our practice. We only have wherever. And we say, well, actually, you don't know whether the next patient you have is going to be autistic or may have a learning disability, or the older generations don't tend to have the diagnosis.
Yes.
It's been bypassed. You do not know. So we're trying to reduce that risk. I don't think we'll always be able to, get rid of it altogether.
It's funny you should say that with older people not having that diagnosis, because that's sometimes the rhetoric that you hear of, we never had any of this autism back in my day. Like, it was there, but as you said, it was undiagnosed in a lot of people. I suppose I guess how do you get or maybe encourage, care homes, people working with older people to have that understanding as well?
So at the start of this podcast, I talked about knowledge and education. And it comes back to that again, time after time after time. It comes back to educating people. It's difficult when people don't want to be educated. It's difficult when people don't always respect neurodivergent people. But this is a them thing rather than a those thing.
Yeah.
And it says an awful lot about those that don't want to be educated. It's awful, really, isn't it?
Yeah. I think the interesting thing is families will notice those subtle changes long before people get to any form of crisis point. What kind of signs or warnings did you recognise that professionals dismissed, and how can services learn to value that knowledge that you mentioned?
I think in Oliver's case, it was very different because he'd been brought to hospital having seizures. And of course, Oliver's training is all about understanding reasonable adjustments. And reasonable adjustments were not made for Oliver in any way, shape or form. Practitioners were not prepared to listen to Oliver himself. They were not prepared to listen to us. And they certainly were never going to make reasonable adjustments purely because they didn't understand the reasons why and what that could do to help Oliver and help themselves. So what they didn't see in Oliver, like I said, he was having seizures, which made him scared and anxious. And instead of, like I said, listening first, but instead of backing away and altering their communication methods because, practitioners would stand over him and they would speak in medical jargon. And that you could see the anxiety from the practitioners and that impacted Oliver and heightened his anxiety even further. They could have talked about, I think Liverpool was playing that night. Oliver was a massive Liverpool fan. I think the X Factor was on. If they'd have just used humour, and we kept saying that, talk about what's on the TV tonight. That's what he's looking forward to. And it was just totally ignored. But if they'd have understood better and if they'd have used their ears and listened a bit more, that would have reduced Oliver's anxiety hugely. And that came out, and Oliver had a learning disability mortality review investigations. It's known as LEADER. And that actually was one of the biggest points that came out, reasonable adjustments. They should have been made when he was in the A&E department that night. Instead, what they did was increase chemical restraint, ketamine, I think it was ketamine, but all of those drugs were increasing. Those type of drugs don't always work on the autistic brain either. And that can make, rather than sedating an autistic person, it can actually heighten. And that's exactly what was happening to Oliver. So much so, he needs to be intubated in the end. And the seizures were not stopping either. Because, of course, the more anxious he became, the more he was having seizures. So it was just awful, really, really awful.
Do you think, when you talk about not talking to him directly or asking him his needs, was that his age or was that because of his autism?
Absolutely because of his autism, because of his additional needs. He was not seen as a person and he was not seen as relevant. And we were treated very much the same way as Oliver, which was, it cost Oliver his life. It really did. And then, of course, I look back and the neurologist treating Oliver in the A&E department that night, he was really good. He was fantastic. He was trying, but what he was doing was wrong. Later on, what happened to Oliver whilst he was intubated was, it cost Oliver his life. And again, it came back to that situation of people not listening. Absolutely, people not listening to even, Oliver may have not been able to speak for himself, but we were able to advocate for Oliver. But again, that stigma, that bias, it was there the whole time. And that's what I hear from autistic people all the time. And people with ADHD, they are treated so badly.
No, I can definitely relate to that based on the work that we do. I think it's quite interesting working on people with substance misuse problems, especially their interactions with medical professionals, people who are genuinely in pain that can't get prescription pain relief because the doctor just assumes that they're trying to score more, drugs basically to misuse. There is that stigma there that comes with them as well. So that's something that I see very often and definitely something that I can relate to. I guess the part that I've picked up there is misinterpreting that distress. And I suppose in Oliver's case, distress and neurological symptoms were repeatedly misread as behavioural or psychiatric, leading to, again, as you said, inappropriate medication, which had devastating consequences. In drug and alcohol services, where prescribing, detox and crisis responses are routine, what happens when distress linked to autism and learning disability is misinterpreted as substance use, challenging behaviour, or non-compliance?
It's just totally unacceptable, because the one person who asks for help and support, they're the ones who are abused by the very people, in a way, so I will use that language, abused, by the very people who are there to help them most. Now, again, we don't point fingers at people, at professionals, because we need to bring them on that journey of better understanding to enable them to better support our neurodivergent communities. But again, it comes back to that not understanding autistic behaviours, the meltdowns, the stimming, the communication, the withdrawal. As in, and by that, I don't mean withdrawal of drugs. I mean the withdrawal where an autistic person or a neurodivergent person might be overwhelmed. They're in sensory crisis. And of course, when a person is in sensory crisis or sensory overload, their behaviour becomes heightened. That's not behaviour. I see that as communication. A person is actually trying to communicate a need, and a professional has a duty. They do have a duty to understand that need, and chemical and physical restraint is not the answer. Listening, talking and understanding. Oliver's training is all about ask, listen, do, and learning directly from the person. That's where we will get the answers. That's where we will be able to support better. And at the end of the day, that's why professionals are in this job at the very start. But we've got to learn to listen to our neurodivergent communities far, far better.
I think this was something that I found really interesting within the training, thinking about our client base and who we work with. The amount of times that I've seen the people who are accessing our services labelled as chaotic, when my opinion after doing that training is how many of those are, in quotations, chaotic, and how many of them are feeling overstimulated by the environment. Our reception area specifically, it can be so overwhelming. I feel overwhelmed as a staff member in there, let alone someone in there who's trying to access, service support. I just found that really interesting about the in the way that we communicate with these people and how are we getting this so wrong in the terms of this blanket response to everybody having the same service as they come in, when all those needs, as we said beforehand, in our service in Hull alone, there's over 3,000 people that are accessing that service. The differences in those, how many of them are undiagnosed as well? Do you know what I mean?
Well, exactly. And people are first of all, they're labelled because they've got an addiction.
Yes.
So we've got the bias going on there. Throw in that somebody is labelled as autistic, labelled as having ADHD, maybe OCD. But it's exactly what you've just said, that environment, which is not adapted. It's reasonable adjustments.
Yes.
It's not adapted to meet the need. And people just need to step back and ask, listen and do. It's not hard. It's really not hard. Is it so hard to ask a person when they come into that reception area, how are you feeling right now? What can I do to help you? What things can we do to make things a bit easier for you to access our service? Is that really a hard thing to do? But instead, the fingers are often pointed at them. They're labelled as you said, chaotic, difficult. They won't engage. When in actual fact, it's the professionals who are not engaging because they're not stepping into that person's life, into that person's head to see exactly what's going on and what we can do better.
It's the one thing that I've always found interesting when people are, as an example, kicking off in the reception area. And the example that I give when I'm delivering training around conflict resolution, we'll say for lack of a better word, is if someone's coming in and they're upset that their methadone prescription isn't in the chemist, that's come from a place of, it's almost like the brain's now just gone into overdrive, and it's like, oh, my prescription wasn't at the chemist. That means I'm not going to get my methadone. That means I'm going to have to score drugs. They go to the service, they explain that it's not there, and then they're sat in the reception. Then whilst they're sat there in the reception, they're thinking, I'm going to have to steal. I'm going to have to, go on the rob. I'm going to have to borrow money. I can't afford to borrow money. I'm going to have to borrow drugs off someone. But then that person, and it's just on and on and on. And then you often find that once you sort of find the situation as, right, the prescription's here, there was a reason why it wasn't sent to the chemist, you address that. There's almost like this deflation of relief. But the hard part there is when they're just left to just sit in the reception whilst all this is going on in their head, which naturally, that's where they're going to get agitated. That's where again in quotations, the chaotic behaviour is going to come from.
Well, they don't feel listened to.
Exactly,
and this is why it was essential that receptionists do receive Oliver's training tier 2. They've got to, people do need to understand that this is communication. This is actually a very frightened person that sat in that waiting room. The waiting room itself is unpredictable. The unpredictability to the neurodivergent brain is really, really hard to deal with anyway. Their anxiety is going to be through the roof. If that had been addressed at the start of when that person walks into that room, things could be very, very different. I don't know the answers, but I'll tell you who does. I'll tell you who does know the answer. The person who is having a withdrawal from that's needing the methadone. Just when they're in a better place, ask them, what could we as an organisation have done better? What could we have done to help you best when you're in that situation? The answer is there.
So previously, I've worked in the service for 10 years. Previously, I've seen it's almost straight to punitive measures of that person's banned, they can't come here anymore. And it's like, that's not the way to go about this situation.
Well, it's not, is it? Because why is the service there in the first place?
Exactly.
If you're going to push people away that need it most, people who are accessing that service, they all need it. But the neurodivergent person, the autistic person, the person with ADHD and all the other diversities that need it most. And if we're pushing them away, where is that going to lead? Obviously, the mental health is going to increase. The desperation that leads on to inpatient care. You think about the money that will involve. That then leads into physical restraint. It leads on to chemical restraint. The impact of what we do as professionals is significant to those communities, and it's all because we get it wrong. We get it wrong, and that's our lack of communication and understanding.
In highly risk-averse services, I think decisions can be driven by that managing organisational risk rather than individual safety. I suppose, how did that defensive practice play out in Oliver's case?
Well, obviously, it cost Oliver his life, didn't it? It's a difficult one to answer, really, because if I think about it, that defensiveness, we were just ignored. They didn't have to get too defensive because they were just, I can still see to this day, 2 consultants. One was the neurologist, not the one I mentioned earlier on. And another one was the intensive care doctor. And we both pointed out Oliver's eyes were looking really puffy. He was looking blue around his eyes. And I can still see them to this day. They didn't even acknowledge that we'd spoken. That I can still see them. It was like a pair of curtains. They'd turned their backs on us. And at that point, if they'd have listened, we now know that's when Oliver's brain was swelling. And what your listeners might know is that Oliver's brain, as a result of that drug that was given, it swelled so much it was bulging out the base of his skull. Now, that was obviously the temperature was rising. That was one of the things that were causing it. If they'd listened at that very point, that could have been prevented. Something could have been done, and Oliver's life could have been saved. So again, it was this arrogance, isn't it, really?
Yeah, I think the part that I found, the entire story is heartbreaking, but you talk in the training about how his eyes were rolled into the back of his head for almost half an hour. And it was almost like they thought he was making it up.
Oh, do you know, that was back in the children's hospital.
That was awful.
That's called ocular gyrate crisis, and we didn't know what it was. And neither did poor Oliver, he kept apologising. It was horrible. And hopefully in this podcast, you can show that photograph. It's quite a traumatic photograph. So he'd been given a drug, which I won't mention the names of these medications, and it was a antipsychotic drug. And they'd obviously given him too much. He didn't need it. He was just a kid, and he was actually in the hospital, and he was bouncing his ball. He was massive. He played for England development squads, and they'd given him this medication, and it's called ocular gyrate crisis, and it's a dystonic reaction, and it's very painful, and your face becomes frozen, and your eyes, like I said, are rolled up at the back of your head. It's horrible, and you need a medication that can counteract that reaction. But I heard the neurologist, she was there, and she said she'd never met Oliver before. He's making her up, it's behavioural. Like in Oliver's story, he was a goody two-shoes. He'd never had a detention. He was known for his manners. He was just everybody's friend. So it was really, it was awful to hear him being labelled in that way. And it was only, like I said, after 6 hours when she realised, 6 hours they left him.
6 hours, wow.
6 hours. When she realised he'd not changed from that position of that frozen face. Procyclidine was the medication. And, it took 15 seconds.
That's 15, the part, yeah.
And that is discrimination. He would not have been treated in that way. And, I do an awful lot of presentations. And I often say, if Oliver had not had a label attached to him being autistic and he had a mild learning disability, if I'd have gone into the hospital, I definitely would not have been left for 20 minutes like that. Nobody else would have done. But because he had labels attached to him, this is why this happened to Oliver. And this is happening actually to a lot of autistic people who are sectioned, who are hospitalised in hospitals, care homes across the country. And that is a reality. And that's wrong. That is wrong. Again, that's stigma, isn't it? And it's bias.
I guess going back to the labels that we talked about, like chaotic, Oliver was described by the professionals as challenging, or that was behavioural at points where his needs were not being understood or met. In addiction services, people are often, again, labelled as chaotic or difficult. I guess, how does Oliver's training help practitioners pause, question those labels, and begin to understand what really might be going on for that individual?
Well, Oliver's training, first and foremost, has been designed by autistic people and people with a learning disability. So it's all about learning directly from them. And that's what it's all about. It's about asking, listening, doing. It's about understanding the laws. It's understanding communication needs. It's understanding reasonable adjustments. And it's for our practitioners, the value behind that is that our practitioners will learn to understand directly from our neurodivergent communities. That is essential. I often say, and it's a bit crude, there's nothing worse when a man doesn't understand a woman's private needs, vice versa. So why would we want to learn something if it's not coming directly from that person? It doesn't make sense to me. We have to, we've got to step away from the medical side of things and learn, separate it and look at the social and learn directly from these communities. That's what it's all about. We need to stop labelling. And by that, I mean behaviour, challenging behaviour, chaotic, nuisance. There's a lot worse names than
we hear them all the time in services as well.
I think we need to humanise our neurodivergent communities. We need to start to see them as people and as equals. I often think, actually, is neurodivergent becoming, are we more neurotypical? I think there's a lot more people that are autistic than we realise. And as you said, undiagnosed. I think it's time to just stop and think and consider and be curious and ask questions. One
of the things I loved about the training, it was a co-produced piece. It's a relatively small thing, but those that we're talking was labelled as experts by lived experience, and I love that. In addiction services like ours, I've often used the words like just those with lived experience, or recovery champions, or peer mentors. But when I saw experts by lived experience, I was like, that's incredible, because you just said nobody understands that more than that person
course.
who is living it.
Of course. You know, I think it's awful that, you know, the literature out there about autism, how it's diagnosed, and so on, that's been derived from non-autistic people, people who don't have ADHD. People write, and we all learn from people who are not always autistic themselves, who don't have that need. And I just actually can't get my head around that. I think that's awful. It really is. You know, I'm not being funny. I don't know anything about you. First time I've met you. Can you imagine me writing up a paper all about you? But I don't know you.
See, there's a little side note. So I'm bald now, but I used to have bright ginger hair. And I was quite happy to be known as the ginger-haired kid. And it was funny when someone said, oh, you're not allowed to say ginger now. You have to say strawberry blonde. I was like, no, I'm ginger. I prefer ginger. But it's often that is the case. And it's people speaking on behalf of other people,
Absolutely.
for other people. And you just can't get your head around that. But the experts by lived experience, I was like, that really brings that together.
It's important. It's really important. We need to hear how best to help and support these communities by hearing directly from them. Again, comes back to ask, listen, do, and respect, humanise.
Reasonable adjustments is an interesting one for me, because I think services often say they make reasonable adjustments, but sometimes I still feel like those adjustments still expect autistic people to fit existing systems. What does a genuinely reasonable adjustment look like in a moment of distress for somebody?
I think if the distress, are you able to ask, how best can I help? Anybody that's in distress, I feel the more you talk at a person, the worse it gets. You're going to heighten that anxiety. Step away. If necessary, dim the lights. We can all dim the lights. Don't talk at the person. Move things away. Just step away. Give them space and time. And just let that person calm.
Yeah.
And that's what I would do. But hopefully people would have a health passport. They are invaluable. They give information on when a person is in a calmer space where you know, it will mention their health needs and how best to help them generally, and also in times of crisis. They are invaluable. But a reasonable adjustment is only reasonable and what is available at that time. So, you know, if you go into, especially if you go into our A&E departments right now, there isn't always a quiet room. There just isn't, and you can't always demand that. But what is available is how we communicate, empathy, time, space. You can't always dim that light, you know, and it's getting down onto that person's level. It's what you can do, and it can always be the most basic of things that you haven't even thought of. But if you can, or actually what you should always do every single time is ask the person, their carers and families, anybody that's there to advocate for that person.
Thank you. Listening is obviously, you know, hugely important. And throughout Oliver's care, you and your, you know, family raised repeated concerns, provided clear evidence, and were not listened to. Going back to us and substance misuse services, where risk can escalate quickly, how important is it that practitioners genuinely listen to family and carers when accessing safety, medication, and those discharge decisions as well?
Well, it's essential, isn't it? Because it can save a life and it can take a life if the person themselves, their families and carers are not listened to. You know, that is the ultimate thing at the end of the day. If we're not listening, and, you know, we've got to think about what is listening, because it's got to be effective listening. There's no point listening if you're not going to do anything about it. There's no point providing information or asking a person, what can I do to help you? Because more often than not, people don't know what's available to them. So make sure that you always know what you can do best to help and serve. But I just think this basic dehumanization, this lack of communication skills, this lack of education has such an impact on the person, the very person that you're trying to help. But instead we do get it wrong, and we do stigmatize. And that arrogance and that ignorance is costing lives. And when I say costing lives, that can actually be not necessarily death, but it's the quality of life that
Yes.
we're taking away, and the impact and, what results from the lack of us, and how that results in that person going forward. Homelessness, like I said, institutionalization. What
Both
happens
very
next?
prevalent things in the work that we do as well.
Well, that's what I'm saying. That's what I'm referring to, actually. But professionals, if they don't understand the neurodivergent brain, they can't get to the root cause of why a person has reached for substance abuse. If you don't understand why that person has done it in the first place, how can you help them best? If you don't understand stimming, sensory overload, sensory crisis, if you don't understand why an autistic person seeks to be included, how difficult that is for them, how can you help them best? If you don't even understand the basics, or you haven't even thought to ask the person, because there's so much going on before we even get to the drug abuse or the alcohol abuse or wherever. You've got to understand the root cause first.
There's practitioners up and down the country that will be listening to this as part of their learning and development. If you could say one thing directly to them, what would that be?
See the person. See the person. Think, ask, listen, and do every single time. Ask what you can do to help best. But please always remember, and I would say this directly, I'll look right in the camera, it's not about blaming. It's about all of us working collaboratively, working together to get it right. Because we've got to get it right, and we've got to stop thinking about backfill and costs. Money is important. Of course it's important. But actually saving lives and giving a better quality of life to people is far, far greater. Far greater.
For you specifically, I believe you was often placed in this position of having to explain all of it to professionals with again, goes back to that more formal authority. What does that emotional labour do to families over time?
That's hard.
Yeah.
I think there's a lot of things I've learned since Oliver died. I wasn't perfect either. I would often talk about Oliver to professionals rather than allowing Oliver to speak for himself. And I would do that over and over. Actually doing these presentations, which I do a lot, conferences, NHS trusts, social care trusts. Obviously, I'm talking about Oliver now, and I talk about what happened over and over. I'm able to compartmentalise, but actually, it probably is very hard when you think about it. But families, for me, I think every single time, if an autistic person, ADHD, a neurodivergent person, we've got to enable them to be able to speak for themselves. Obviously there will be people who aren't able to speak for themselves, but who are more profoundly disabled. That's a different situation. But where possible, and that it would be quite a lot of the time, we've got to enable those communities. Their voices have got to be heard in one way or another. We have people who are, as I've just said, unable to talk, but there's other ways of communication, and we've got to learn how best to help them. There's lots of different ways to communicate.
Thank you. I think most of the professionals involved in Oliver's care may believe that they were acting in his best interest, yet the system obviously failed him. In drug and alcohol services like ours, staff often see themselves as compassionate and well-intentioned. Why isn't empathy alone enough to keep people with learning disabilities or autism safe?
Well, empathy is just one part of it. Empathy alone is not going to keep somebody safe, is it? Because we're not addressing the core reason as to why our communities need to reach for substance abuse. So it's not just about empathy, it's about humanisation of people, seeing the person. It's about giving the right support. Empathy should be there all the time. We shouldn't even have to mention that, should we really?
It should be the default, the natural.
But I think our professionals, we need to step back and say, look, if this person is continuing to have substance abuse, if they're continuing on the path that they're on, we have to question, what are we doing as professionals? Where are we failing this person? And I think it's self-reflection is essential. And if we can't do that, then actually I would question, should you be in that profession? If you can't see a person as a human being, should you be in that profession? If you can't question and be curious about how a person thinks and behaves differently, then you should not be in that profession. Like I said, you've got to open that mind and you've got to be thinking differently in order to help that person best.
Absolutely, yeah. Long before the worst outcome, what harm is done when people aren't believed to trust engagement and even that willingness to seek help?
Well, they'll turn away, won't they? And of course, whatever crisis or abuse that they've turned to is going to worsen, isn't it? And ultimately, the quality of life is greatly affected, without a doubt. And then ultimately, it costs lives. But it's not just that person, of course, because of, it's far-reaching, isn't it? The family are impacted, carers. The family dynamics are just absolutely destroyed, aren't they? Sometimes when, as you know from your profession, where drug abuse or alcohol abuse or even gambling, where that comes into play, which can be, I'm hearing, can be quite prevalent amongst the our neurodivergent communities. Isn't it awful? Isn't it terrible that people are desperately trying to live a happy life? And that happy life doesn't exist because society constantly puts pressures on our communities, and they're trying to perform and conform to what they perceive as normal. And that is the impact of not getting the right support at the time of need.
I think it's interesting you said that as well, because one of the sayings that I heard very early on in my career in substance misuse services was nobody goes into addiction alone. And I used to think, well, of course they do. If they're doing that harm to themselves, but you quickly realise, no, it's the impact that has on the families. If someone's there with a heroin dependency, the impact that has on their partner, their mother, the father, their children, it's so widespread. Exactly. It isn't just down to the individual. So with that in mind, I guess if people aren't believed, when they do have the problems that they're having, as you said, they just turn away. And that will only get worse and worse and worse.
So can I ask you a question?
Yes.
How many neurodivergent people do you think access your service?
From the top of my head, I couldn't even tell you, because I don't think it's something that we even ask at the point of assessment if they even believe they may have neurodivergency.
Why don't you ask that question, if you don't mind me asking?
No, well, there you are. If we could, I think that's the one thing I'd like to see based on the training, based on Oliver's training. It's not just about how we interact with people in terms of them attending and coming into the reception area, or if they're presenting, again in quotations, chaotically. It needs to go deeper into every single point of the system. And we should be referring people to try and get that specialist support if they do believe it as well. Because I think the one thing that's interesting around us talking more about neurodivergence, I think more people are starting to possibly recognise those neurodivergence traits in themselves. So at that point of assessment, they might actually be willing to say, actually, now you've asked me, I've never been asked that question before, but now you've asked me, possibly. And then how do we follow up with that in the way that we support people?
That comes back to the start of our conversation. The reason I would say that you probably don't ask is fear. You feel that you might upset the person. You don't want to cross that line. I have a suspicion that might be the case. And it always comes straight back to ask, listen, do, doesn't it?
It's funny you should say that, because I remember being on like this panel thing, and they was doing something around ADHD. And they said, oh, Matt, we've put you forward for it because you're neurodivergent, are you? And I went, am I? And I was like,
I did wonder, if I'm honest.
I could have sworn you was ADHD. I was like, I've never looked into it. I know there are things that I probably do that are quite in line with ADHD. But yeah, I've never gone and sought help for it or anything, But I think I see that in. Sometimes I feel like it has a bit of a strain on my relationship. My wife's quite a tardy person, and she'll get quite frustrated when I've just started one job and then I went downstairs to the tool cupboard to get another one, and now I've just reorganised my entire tool cupboard, and the job I started upstairs still hasn't been done. The way I jump from topic to topic, I start another story when I'm halfway through one story. There's all these little things that I do, and I think maybe the reason why if it is there, why I haven't sought help is because I've never felt like it's had too much of a negative impact on my life. But it was interesting when I did get asked, are you neurodivergent? I was a little bit like, I don't know. Am I?
Honestly, I'm asked the same question.
Mm.
And I have a few suspicions about myself, but I don't feel the need either to get the diagnosis because I'm supported within my, I can see in myself, I divert from one thing to the next. I'm having your question, you're asking me questions. My brain is also, it's jumped elsewhere already.
Yeah.
Is that ADHD? I don't know, but I am aware that I do it all the time. I can't watch a film without predicting the end. And I do predict it correctly every single time.
Yep.
My husband refuses to watch a film with me.
Yeah. I'm the exact same. Yeah.
I don't know.
So my wife will be asking me what happens next. And I was like, we've never seen this before. But she asked me because 9 times out of 10, I can normally suss out what's happening before it happens.
I can do it really quickly.
Yeah.
Do you know if I am, if I have ADHD or if I am possibly autistic, something I would embrace. But then that's because I'm very fortunate to have, I don't know, I'm just saying. I have a really good family around me and it's not impacted me to the point of the people that access your service or the people who've been stigmatized, who have been treated absolutely awfully. That type of thing. We're smiling, aren't we? We're laughing about it, but we're okay.
Yeah, I think one of the things, and this it shouldn't be the case, but I think maybe one of the reasons why I haven't as well is because I sometimes see it's almost like negative comments where, oh, everyone has ADHD or autism nowadays, and it's like, well, I don't want to be that person who's just saying I have it for the sake of following it. Do you know? I'd rather just kind of keep it.
Do you know what?
Low key.
I've changed things now. I usually say, do they? What makes you think that?
Yeah.
And put it back on them.
Yeah.
And again, it highlights their ignorance.
Yeah.
And actually, do you know, people don't always mean to be ignorant.
Of course,
people want to be educated a bit more. And people read things on social media. And of course, we know social media is not always correct, is it?
It's presented as factual. That's the problem though, isn't it, sometimes? Yeah.
I know. But it's, again, we come back to education. But I was going to say to you, what does the medical model look like for your service? You know, when you've got people coming into your service and they need help, support and treatment, is it set? And is it the same for everyone?
It feels set. I think that's part of the problem with a service like ours is it's often, you often hear the word, the pathways. The pathways.
And who's the pathway for?
Well, that's the thing. It feels like it's almost, here's our model, here's what we give, and we're commissioned to deliver that model. So in this sense, it's medically assisted treatment, which is a methadone program, which is obviously there to help with the withdrawal symptoms. And as they're prescribed, we address the underlying or the other issues that could be there surrounding it. But it feels like this is the model and you kind of have to fit to it. And it's quite hard to deviate away from.
A bit like a jigsaw puzzle and everybody has to fit in.
That's it. Yeah.
So again, I'm going to ask for a little bit of data that you might not know. What's the success rate of this fixed medical model?
Wouldn't be able to tell you off the top of my head.
Ish.
I wouldn't even be able to give a ballpark figure because I think that, do you know what I will say? There's an interesting fact for me that when I look at the outcomes between substance misuse problems directed to opiates, for instance, and those that are struggling with alcohol, the alcohol pathway, again, the use of the word pathways, that seems to have a point of entry and a point of exit, and that seems to flow quite nicely with people coming in the start and then leaving at the end. And I can almost pinpoint that as a straight line. The interesting one about the one for opiates, the medically assisted treatment model, is you're coming at MAT 1. You have the assessment. We basically get you onto what we'd call maybe like an optimum dose of methadone to stop the withdrawal symptoms. And then we can either go to medically assisted treatment stage 2, where we will address any surrounding issues, or if they're quite stable, it might go to a MAT 3, whereas there's the reduction. MAT 4, which is the detox. I'm not a frontline recovery practitioner, so bear with me on that one. But it's kind of like it's across, it's up, it's down, it's backwards a bit, it's forwards again, and it's kind of almost like rather than this straight line, which seems to work with the alcohol pathway, it goes in like spirals and it's back and forth, and obviously there is a success rate there. But I think when I look at people as individuals, I can see why people are struggling with it and why it's not working for certain people. And you may develop a really good rapport with your key worker in MAT 2, and you've addressed your stability, but now we're going to do a reduction. So you move on to a MAT 3 key worker. But hang on, I built up a really good relationship with my MAT 2 worker. Now I have to go meet somebody else. And I understand how that can be so difficult for people as well.
Well, I would question the biggest failings, the group that fails the most on that treatment pathway. Would that possibly be our diagnosed and undiagnosed neurodivergent people? And that comes second-handed, where I will also say, is that because the plan is not differentiated to meet their needs? So it's a two-part question.
It's interesting because I'm actually part of I've just joined a medically assisted treatment working group, basically. And I'm there representing sort of, especially the lived experience voice, managing those lived experience, working with volunteers. I deal with a lot of the service user feedback. And it's interesting that neurodivergence hasn't really come up in that working group yet. And I do think that's definitely the thing that we're going to be taking forward.
Nobody's curious. Nobody's asking.
That's it, yeah.
So again, we come back to that. Why are people not asking that? Are we afraid or ashamed to ask that question? And I have to say, then we must be. Because why aren't we? Because our neurodivergent communities need those adaptations. They need those reasonable adjustments. They're not cushions that have just come in and sat down. They actually need specialised and differentiated help and support. And that's where our practitioners can do so much more. It's not just about Oliver's training. It's about so much more. And again, it's about being curious. It's about asking those questions. Again, it's about working collaboratively with these communities and asking those questions and really, really effectively listening. Not just listening, tokenism, tick boxes. It's about, remember why you're doing this job. Yeah. Why have you gone into this this side of your profession? And that, without a doubt, is to help and support these groups of people. We can't keep them on a pathway that's not working for them. We've got to look at that and address it. And I understand, the pressures from all angles, really. And of course, the funding. But that passageway that you've just talked about is for the neurotypical person. But we as a society have a lot of different people and it does not work for everybody. And my assumptions and my guess is that your neurodivergent communities are failing and it's because they are being failed. And it's what can we do better? And what I'm taking away from our conversation today is that we are not curious. We're not asking the questions. We're almost embarrassed to ask those questions. And I would say from our clinicians as well. Yeah. It's not a dirty secret that somebody might be autistic, somebody might be, ADHD, have ADHD, maybe OCD, lots of those things. Why are we making it sound dirty when in actual fact they are a huge part of our community and they're valued parts of our communities. And we've got to do better. Absolutely. We have to do better, not because we're told to, but actually because we want to do better and we must do better.
I think you mentioned, obviously, just talking about questions there. And just to bring it back to Oliver, is there a question that you wish professionals had asked either yourself or Oliver earlier, one that might have changed the course of what happened? And I know it's hard to deal in hypotheticals, but
how can we help you best?
As simple as that, yeah.
Ask, listen, do.
Yeah.
Treat Oliver as a human being. He had a voice. His voice was valuable. He understood himself very, very well. Just stop and think and remember why you're doing that job. The one question, how best can I help you?
I just want to quickly, and this is a bit of a side question for me, but I am interested in the honours system. You are obviously, is it OBE? Is that correct?
It's an OBE, yes.
OBE. I wouldn't even know how that process starts or how it works.
Neither do I.
I was going to ask, can you tell me a bit about it? But
no, I can.
Go on, please do.
So somebody nominates you,
okay.
and you don't know who that person is.
So, and you still won't know now?
No, you're not to know. So that's my understanding. So it could have been anybody. And then, of course, you get the letter and you're not allowed to say anything at all. And for me, my medal was presented by Prince William, and I really wanted Prince William because we are a military family, we're an Air Force family, and it mattered. It really mattered. But somebody pointed out to me, and honestly, I even get chills now. because I don't take any credit for this. You know, this is all about Oliver, and it's also all about our communities. This is who this is about. And somebody pointed out, OBE, Oliver, behind everything.
Wow.
And I can feel Oliver on my shoulder now. I can feel him, and I do often, actually. So yes, it's lovely. It's lovely to have, but it's that award belongs to Oliver, and it belongs to, for me, I would say it belongs to our neurodivergent communities. I'm just the voice. I'm just a voice.
You say just. I think as someone who does, voice for service user involvement, service user activity, I think this is such an important thing. Just a voice, I think, is actually almost diminishing what you are actually doing.
But I am. The biggest voices are our communities. I'll do my best. I don't get it right every time, but I try. I try to make a difference where I can.
Paula, thank you so much for joining me on Believing People. I like to finish the podcast series with a series of questions, just to lighten the mood a little bit. Sometimes, obviously, as you can see, there's heavy topics that we discuss here. And my first question for you is, what's your favourite word?
My favourite word? Listen.
Least favourite word?
Listen, sorry. Least favourite word? No.
Tell me something that excites you.
Making a difference.
Tell me something that either bores you or drains your energy.
People that talk rubbish.
What sound or noise do you love?
Oh my goodness, I don't know.
It's an interesting one, isn't it? I always found it. Do you know what's interesting?
Sound or noise? I don't know. The school bell.
Is there a sound or noise that you hate?
High-pitched screaming noises.
When do you feel most like yourself?
Oh gosh, that is a really, really interesting question. I think since Oliver left, I don't even know who I am anymore. I'm just Oliver's mum. That's an interesting question. What profession other than your own would you like to attempt? Oh, do you know, I was always going to go into the medical profession. And because my husband being in the Air Force, I needed to be doing what I was doing. And I was always going to go into therapy to support children going through cancer and different things, midwifery as well at one point. I'm a bit old now. I'm 60, I'm old. So do you know what? I think we're put on this earth for a reason. I've lost Oliver, but I think I was put on this earth to do what I'm doing right now. That's nice. I think so. What profession would you not like to do? A profession that causes harm, like abattoir or that type of thing. Yeah. And lastly, if heaven exists, what would you like to hear God say when you arrive at the pearly gates? You made a difference. Brilliant. And Oliver's here. Paula, thank you so much for joining me on Believing People. Thank you. Thank you for having me. And thank you for doing the work that you do. Thank you. It's very important. I appreciate that. Thank you.